Today we are going to talk about Missouri Cancer Registry's required site-specific data items for brain, liver, melanoma, plasma cell myeloma, and plasma cell disorders. My name is Jennifer Sedovic, and I will be the presenter for this topic. I would like to thank Babette Langeneckert for creating the slides for this presentation. I would like to acknowledge the source of our funding. The Missouri Cancer Registry and Research Center is supported in part by a cooperative agreement between the Centers for Disease Control and Prevention and the Missouri Department of Health and Senior Services, and a surveillance contract between DHSS and the University of Missouri. Our agenda for today will be to understand how to code the following SSDIs required by the Missouri Cancer Registry. For brain, we need to code brain molecular markers, liver, fibrosis score. For melanoma, we need to record the Breslow tumor thickness and the LDH Pretreatment Lab Value. For plasma cell myeloma and plasma cell disorders, we record the LDH Pretreatment Lab Value. We are going to start on brain molecular markers. Description: multiple brain molecular markers have become standard pathology components necessary for diagnosis. This data item captures clinically important brain cancer subtypes identified by molecular markers that are not distinguishable by ICD-03 codes. Coding instructions and codes. Note 1. This data item applies only to ICD-03 histology codes 9400/3, 9401/3, 9440/3, 9450/3, 9451/3, 9471/3, and 9478/3. If a histology is not included in this list, assign code 85. Note 2. Physician statement of histologic subtype can be used to code this data item. Note 3. Only one code is applicable for each tumor. IDH mutation status distinguishes between clinically important subtypes within ICD-03 9400/3, diffuse astrocytoma, and 9401/3, anaplastic astrocytoma. IDH mutant and 1P/19Q code deletion distinguishes between clinically important subtypes within ICD-03 code 9450/3, oligodendroglioma, and 9451/3, anaplastic oligodendroglioma. IDH wild type distinguishes clinically important subtypes within ICD-03 9400/3, diffuse astrocytoma, 9401/3, anaplastic astrocytoma, and 9440/3, glioblastoma, epithelioid glioblastoma, and glioblastoma NOS. Note that the new ICD-03 code 9445/3 applies to glioblastoma, IDH mutant. Information regarding this subtype is not collected using this data item. SHH activation and TP53 wild type distinguishes between clinically important subtypes within ICD-03 histology code 9471/3 medulloblastoma. C19MC alteration status distinguishes a clinically important, highly aggressive subtype within ICD-03 9478/3 embryonal tumor with multilayered rosettes. This is the brain molecular markers table. You can code 01 for diffuse astrocytoma IDH mutant 9400/3, 02 diffuse astrocytoma IDH wild type 9400/3, code 03 anaplastic astrocytoma IDH mutant 9401/3, code 04 anaplastic astrocytoma IDH wild type 9401/3, code 05 glioblastoma IDH wild type 9440/3. You can use code 06 for oligodendroglioma IDH mutant and 1P/19Q co-deleted 9450/3. Code 7 anaplastic oligodendroglioma IDH mutant and 1P/19Q co-deleted 9451/3. Code 08 medulloblastoma SHH activated and TP53 wild type 9471/3. Code 09 embryonal tumor with multilayered rosettes C19 MC altered 9478/3. You will use code 85 not applicable, histology not 9400/3, 9401/3, 9440/3, 9450/3, 9451/3, 9471/3, or 9478/3. Code 86 is used for benign or borderline tumors. Use code 87 when test is ordered, but the results are not in the chart. Code 88, not applicable, information not collected for this case. If this item is required by your standard setter, use of code 88 will result in an edit error. Code 99, if it's not documented in the patient record, or no microscopic confirmation, or brain molecular markers not assessed or unknown if assessed. Examples: biopsy of a brain tumor, microscopic confirmation diagnosis, diffuse astrocytoma 9400/3, additional testing done, and IDH mutant is identified, code 01. Diffuse astrocytoma IDH mutant 9400/3. Example 2, biopsy of brain tumor, microscopic confirmation diagnosis, anaplastic astrocytoma 9401/3. No further testing or results unknown, code 99. Example 3, MRI of brain tumor, clinical diagnosis, glioblastoma. No further workup, code 99. Example 4, biopsy of brain tumor, microscopic confirmation diagnosis, mixed glioma 9382/3, code 85, not applicable. We are going to go ahead and move on to liver. And the fibrosis score? The definition is the fibrosis score is based on degree of parenchymal fibrosis or cirrhosis of the non-tumorous liver as defined in the surgical pathology report. Coding instructions and codes for fibrosis score. Note 1. Physician statement of fibrosis score can be used to code this data item when no other information is available. However, code 7 when the physician statement of fibrosis score is not based on histologic examination of the liver. Note 2. FIB-4 is not a pathological fibrosis score of 4. It is a scoring method using the patient's age and relevant lab values to calculate a score. The medical record may show something like FIB-4 equals 3.52. Do not code FIB-4 values in this data item. Note 3. AJCC classifies ESAC fibrosis score 0 through 4, none to moderate fibrosis, as F0, and ESAC fibrosis scores 5 through 6, cirrhosis, severe fibrosis, as F1. This is not the same as MEDAVER score F0 or F1. Note 4. Record the results based on information collected during the initial workup. If multiple biopsies are taken and have conflicting scores, use the results from the biopsy closest to the start of treatment. Information collected after the start of treatment may not be used to code this data item. More coding instructions and codes for fibrosis score. Note 5. To use codes 0 and 1, you must have a histological microscopic confirmation of fibrosis cirrhosis. Code the absence, code 0, or presence, code 1, of fibrosis as documented in the pathology report. Note 6. Use code 7 if there is a clinical diagnosis, no microscopic confirmation of severe fibrosis or cirrhosis. Note 7. If no score is mentioned, descriptive terms may be used to assign codes 0 and 1. See specific terms in the table. Note 8. If a fibrosis score is stated but the scoring system is not recorded, consult with the physician. If no further information is available, code 9. This is the fibrosis score table. You can code 0 for ESAC fibrosis score 0 through 4, no to moderate fibrosis, MEDAVER score F0 through F3, but Ludwig score 0 through 3. Code 1, ESAC fibrosis score 5 through 6, advanced severe fibrosis, MEDAVER score F4, but Ludwig score 4, developing cirrhosis, incomplete cirrhosis, transition to cirrhosis, cirrhosis probable or definite, cirrhosis NOS. Use code 7 when clinical statement of advanced severe fibrosis or cirrhosis and no histologically confirmed or unknown if histologically confirmed. Code 8 is not applicable, information not collected for this case. If this item is required by your standard setter, use of code 8 will result in an edit error. We are going to move on to melanoma of skin. We require Breslow tumor thickness, which is a measure of how deeply a melanoma tumor has grown into the skin. The tumor thickness depth is usually measured from the top of the tumor to the deepest tumor cells. If the tumor is ulcerated, the skin is broken. It is measured from the base of the ulcer to the deepest tumor cells. Coding guidelines for Breslow tumor thickness. Code a measurement specifically labeled as thickness or depth or Breslow depth of invasion from the pathology report. In the absence of this label, a measurement described as taken from the cut surface of the specimen may be coded. And in the absence of either of these labels, the third dimension in a statement of tumor size can be used to code this field. If the tumor is excised post-neoadjuvant treatment, tumor measurements cannot be compared before and after treatment. The same code, XX.9, is used for cases with no surgical procedure of the primary site and cases with surgical procedure of the primary site after neoadjuvant treatment. Because the thickness table is similar to many other tables that collect the measurement, it is important to identify the correct unit of measurement. Some more coding instructions and codes for Breslow tumor thickness. Note 1, physician statement of Breslow tumor thickness can be used to code this data item. Note 2, code Breslow tumor thickness, not size. Record actual measurement in tenths of millimeters from the pathology report. Measurement given in hundredths of millimeters should be rounded to the nearest tenth. Examples, 0.44 millimeter would be 0.4. 1.12 millimeter would be 1.1. 2.56 millimeter would be 2.6. 11 millimeter would be 11.0. Note 3, code the greatest measured thickness from any procedure performed on the lesion, whether it is described as a biopsy or an excision. For example, if a punch biopsy with a thickness of 1.5 millimeter is followed by a re-excision with a thickness of residual tumor of 0.2 millimeter, code the 1.5 millimeter. Note 4, if there are multiple procedures and the pathologist adds the measurements together to get a final Breslow's depth, the registrar can use this. Do not add the measurements together, only the pathologist can do this. Note 5, if the pathologist describes the thickness as at least, use the appropriate A code. An exact measurement takes precedence over A codes. If the pathologist states greater than instead of at least, code to XX.9, unless it is greater than 9.9 millimeters. Then code AX.0. Examples. Pathologist states the thickness is at least 2.0 millimeters. Code A2.0. Pathologist states the thickness is greater than 4 millimeters. Code XX.9. This is the Breslow tumor thickness table. Code 0.0, no mass tumor found. Code 0.1, when it's greater than 0.0 and less than or equal to 0.1. Code the exact Breslow tumor thickness in millimeters when it's between 0.2 and 99.9. Use XX.1 when it's 100 millimeters or larger. Use A 0.1 through A 9.9 when it's stated as at least some measured value of 0.1 to 9.9. Use AX 0.0 when stated as greater than 9.9 millimeters. XX 0.8 is used when it's not applicable, information not collected for this schema. Again, if this item is required by your standard setter, use of code XX 0.8 will result in an edit error. XX 0.9 you can use if it's not documented in the medical record. If it's microinvasion, microscopic focus of foci only and no depth given. If it cannot be determined by the pathologist. If it's in situ melanoma. And if the Breslow tumor thickness cannot be accessed or unknown if accessed. We will now move on to plasma cell myeloma and plasma cell disorders and melanoma of the skin. These require the LDH Pretreatment Lab Value. LDH, lactate dehydrogenase, is an enzyme involved in conversion of sugars to energy and present in most cells in the body. Elevated pretreatment LDH is an adverse prognostic factor for plasma cell myeloma and melanoma of the skin. Rationale: LDH, lactate dehydrogenase, pretreatment level is a prognostic factor required in AJCC 8th edition for Chapter 82, Plasma Cell Myeloma and Plasma Cell Disorders, and Chapter 47, Melanoma Skin. Coding instructions and codes for LDH Pretreatment Lab Value. Note 1. Use the reference ranges from your lab to determine if LDH is normal. Note 2. Record this data item based on a blood test performed at diagnosis before treatment. In the absence of the lab test, a physician's statement of the exact value or interpretation can be used. Use the highest value available. Note 3. If there is no mention of the LDH, code 9. This is the LDH pretreatment lab value table. Note 4, if schema discriminator is 1, plasma cell myeloma terminology is coded to 1 or 9, and leave this SSDI blank. You can code 0 for normal LDH level or low below normal. Code 1 for above normal LDH level or high. Use code 7 for test ordered results not in chart. Or you can code 9 for not documented in medical record, or LDH pretreatment level not assessed or unknown if assessed. This is a list of the sources that we used in this presentation. We used the site-specific data items SSDI manual. If you have any questions, we can be reached at our toll-free 1-800 line. Thank you for viewing our YouTube presentation.